What if you rebuilt Medicaid E&E as an example? What if you rebuilt behavioral health for the 21st century? Let's remove everything that came before that. What might that look like?
Yeah.
A state that we operate in that will go unnamed, it doesn't validate what number you're putting in for the phone number. So you can get numbers like 1111111, right? That's obviously not a real phone number. Very easy way to prevent that from happening.
The deeper you go in healthcare, I think the more people get disillusioned and the more people feel disempowered to actually change stuff. When in reality, like, it's just a complex web of systems that are not perfectly designed and will never be perfectly designed, but there's always going to be ways to jigger and shift stuff.
Yeah. We live demo the product all the time. It does make a difference for them to see what the consumer experience is in a real way. Even if you make a mistake as you're going through your live demo, that feels real, that shows who you are.
All right, Nikita, thanks for being here. Super excited to have you. It's been really fun to get to know you and become friends. You're also, I think, pretty well known as like the Medicaid MCO whisperer in the tech world now. And so I want to start by just hearing, like, what do you think you understand about Medicaid and MCOs that has allowed you to be so successful with Fortuna that other healthcare founders or other people in healthcare have not been able to figure out?
Well, I'm flattered. I didn't know anybody called me or called us the whisperers. I think a lot of it just maybe comes down to partially personality. We're not salespeople by nature, and I think because of that, it actually lends us to listening. And I think the people that we sell to don't feel like they're being sold to because they're with people that understand their problems and are here to solve and partner on that. I think the second part is we are deeply obsessive about the Medicaid space. That is all I read about. That's all I think about. And I think that passion really exudes when we are talking to some of our plan leaders and plan partners. And then the last thing I would say is solving a crystal clear problem for plans. If you know exactly what their problem is and the number that needs to be changed or impacted, can you really clearly show them how you're impacting that number with no bells and whistles? Like, you're not coming in to create or try to compel them on a story that they have to believe and do some creative accounting to get there. We're pretty straightforward in our model of, here are all the people that are touching Fortuna, here are all the people that are renewing. You see the proof point in your own data because you get it from the state. So I think those three things like really work out.
Yeah.
Yeah.
I love it. And I'm like, I often am jealous of what you're building because the problem and solution is so clear and like so obvious that if you do the thing that you set out to do, which is keep people enrolled, get people enrolled, and do that well, like it is a clear ROI for plans in a way that I think a lot of clinical intervention models on the services side or on the other sides, like it's just harder to prove that. It's harder to attribute, right? If you're talking about how do we keep people out of the ER, which is one of our main value props, it's like there's potentially a lot of different people who touch that patient in there. So attribution is hard, but like, so I'm jealous of your ability to walk in and be like, here's confidently A and B, we do it. It's no surprise that is a factor of why it's worked so well.
But I'll say, like, as a challenge for us that is maybe easier for you, we're often a 1, 2, maybe 3 time interaction for a user, right? You have enrollment or renewal as a key action that only happens a handful of times.
Sure.
Otherwise, we're not interacting as much with a consumer. We're hoping to change that over time, and as we add new features, some of the federal policy changes, I think, have forced our hand to move faster there. But that's the difference, right? With behavioral health or with any services, you usually touch them more. So in that way, maybe you have an even deeper relationship with consumers than, we do.
Potentially. We're going to talk a ton about the federal Medicaid landscape. I think before we jump into that, I want to sort of stay focused on like what you've learned in helping support plan executives and helping them meet their financial metrics, helping them stay compliant. Like, what are some things that you feel like, maybe what is like one thing that you feel like was a non-obvious thing that you learned about how to actually drive value for plans, or on the converse, what was like a non-obvious problem or pain point that maybe every plan that you talked to had, but nobody was speaking out loud to?
One, I'll say that is a data related thing, and another that's more of a financial related thing. MCOs, but plans in general, they do have a lot of data, but they're also limited in the data that they get, and that data can often come 6 months later or even a month later, right? You could have or should have made the intervention if you had that data earlier. So part of the product that we've built allows that information to be far more real time, also status oriented. So you know if someone's 50% the way through. Today, that information from the state, you don't know. So that type of data, I think, is really tactical and helpful. And that was, I would say, partially obvious, but the ways now that we work with them using those interim statuses and getting that data to them before they used to get it has been helpful. So that's like a data piece. Is it helpful to go into more detail?
Well, I'm honestly just genuinely curious. So like, it sounds like the data that plans have is potentially not as high resolution as you would hope, but there is sufficient there. Do you feel like there is a wealth of opportunity to actually leverage that in terms of better insights, better care navigation, better direction, that you feel like most people are not tapping into? Is that sort of what you're saying, or am I missing?
No, I realize I should actually go into details. So the states typically give plans what's called their 834 data. The 834 data is membership data. So it's your coverage dates, it's the family, so your household, the subscribers that come under it, the zip codes that they're in, the type of Medicaid that the individual is, if they're a child, so if it's CHIP or if it's Medicaid, if they're expansion population, all of that comes in that file. Depending on the state, sometimes you get that file every day, sometimes it comes in once a month, and it's a snapshot in time. So given that, you can only do so much with that data. Some states, by the way, don't even give you anything other than a phone number. So you don't get, even if you input to the state that here is my email address, the state doesn't give the plan some of that information. So that's what I mean when I talk about data and how that data gets sent to the plan. There are a lot of challenges and limitations with the 834 that everybody in the ecosystem is pretty aware of.
Okay.
So part of what we do is sit upstream and next to the 834 data to help plans. So contact information, understanding and giving that status of, the end of coverage date is at the end of the month, but now we can tell you that the person submitted their renewal, or we can tell you the household is 75% the way through. We just need to provide income verification. So all of that we can give you every day, every week, however you need it as a plan, really helpful. So that's what I would say in terms of like solving and answering some of their data needs without us even knowing that how much of it was needed. Then the second thing is more around margin. So different Medicaid members and Medicaid populations have different margin associated with them. It's part of the big federal conversation as well, but as a plan, you're impacted by that. So as an example, if you have a long-term care plan, the capitated payment or the payment you might get from the state could be $1,200 a month per member. For someone who's TANF or Magi Medicaid, that's $300 per month. So that margin spread ends up mattering to you and directs how you invest and put resources, operations behind different things. So one of the things we've been able to support on too is because we serve a lot of different types of consumers is create opportunities to expand margin for plans just by helping be efficient in how we support them on renewal.
When does Fortuna launch a primary care clinic to do risk adjustment during the enrollment process?
Never. I used to work on risk adjustment at Oscar, so I have some thoughts and feelings on that. But these are all the things, and I'm curious how you feel about this. As a founder, when people want to get into healthcare or work in healthcare, I've been in the space for 8-9 years now, and I worked at a health insurer. So understanding truly what they care about has helped us be really successful. And if you're building in healthcare but come outside, come from another industry, you may build a great product, but selling to plans or even health systems speaking this level of language and granularity can sometimes be the difference between, yes, you have an amazing product, but speaking the narrative in a way that gets them to say yes versus, here, this is a nice shiny toy, but it's not solving my problems.
Yeah, I mean, I feel like it's deeper than that too, because like, if you're, I've shared this example on other podcasts. Like if I invented a magic pill that I gave you and it guaranteed that you would live till you were 105 and then you would drop dead one day and that would be it and you would live perfectly healthy, but it was really expensive and you had to do it today, but that it's, 1/100th of the cost of your overall health expenditures, nobody would buy it because no one is accountable for that sort of health span. And so I think when you build products, if especially if it's not a product that is solving a direct pain point or revenue like the one that you're doing, if it's sort of like a clinical intervention or something that's really trying to help patients, you have to sort of weigh the balance of like, how do I drive in-year savings while also driving long-term health outcomes? Because if I can't do the in-year savings, if it's new, I have no way to compel people to actually take a shot at this. If I can't drive long-term health outcomes, what am I doing anyway?
Yeah.
I'm just sort of a leech on the system. And so that's, I think, can be challenging for some products. I think there's probably a way to do it for most, right? I think like if you have a product that does not derive any value to a health plan or a reduction in cost in the system in the first year, like the return year 2 or 3 better be really good. But the way you structure and build the thing from the get-go needs to be with the thinking of, I have to be able to drive a financial ROI, or at least plausible financial ROI in the short term, so that way I can lead to the long-term outcomes that I actually want for my patients, which is frustrating because you're thinking about multiple stakeholders when in reality, we probably all just want to be thinking about the patients, but it's not that simple.
You're spot on. Some entity has to get financial benefit at the end of the day. The alternative is you just build a consumer product and you don't have to worry about that. Nobody but a consumer is paying for it, then you don't have to worry about this. But we even hear, when you go to closed door dinners or off the record conversations with leaders in healthcare, one of the things that I hear occasionally is we might make the investment and put in the time and hopefully take care of someone. But if they switch to a different health plan a year later, that health plan actually gets the gains. I spent the resources, but this other health plan is going to reap the margin reward. It's really, it's not growth mindset, but it's scarcity mindset. But I get it as well, just given the way some of the ecosystem is architected.
Yeah, it's also potentially wrong, given that there is annual risk adjustment and there is annual capitated rate adjustments. And it's like, especially in Medicaid, like, okay, we're managed care, you guys are competing, but like, you're extensions of the government providing services to low-income folks. Like, the job is to help people. It's not to, obviously it is to compete and we want everyone to be financially successful, but like at the end of the day, like we're on the same team here. So it's both interesting to me that those conversations are happening, and I hope, my naive hope is that everyone also feels on the same team.
Yes, and I should clarify, didn't just mean Medicaid, I mean generally health plan leaders, if you think commercial leaders, Medicare.
Talk about a benefits person at an employer. It's like, I'm putting together a compelling benefits package for my employees, but if they're going to stay for 18 months because they're going to go to Facebook and on Google, like it's hard. And then it just becomes hard in the ecosystem to build anything that drives long-term value, which I think is sort of the negative perspective. I think the positive perspective is like, there's lots of problems to be solved. There's lots of improvements that need to happen. And there's lots of ways to drive short-term return on investment.
Yeah, I think that's part of the way you have to sell to a plan or a health system is there has to be a short-term story and there has to be a long-term story. Unfortunately, that's just how I found a lot of the sales process needs to work. So you're a killer if you can come in and have a short-term gain very quickly and show them the numbers, show them the ROI if that's possible in a 3-6 month period. And then it's gravy. It's amazing if you can do the 2 to 3 year ROI. But a lot of folks are really looking for can you show the results to me in 3 months, 6 months.
Yeah. What have you, in all of your work with MCOs to date, there's obviously a million competing priorities that everyone's trying to tackle. There's duals, there's behavioral health, there's enrollment, there is federal changes to the FMAT. Like there's there's so much stuff. How have you seen people who come to Fortuna very interested in the product with potential questions about where it lands in their hierarchy, and sort of like, what have you seen people be successful in terms of convincing and building internal gravity to actually deploy? You can use Fortuna as an example, but I think more broadly, like, how have you seen people build internal momentum to actually get things done for the plan for patients?
Yeah. What I would say is every plan internally has their set of priorities, usually 1, 2, 3 top priorities. Sometimes those are shifting, but usually they're related to cost containment. They're related to quality and making sure that you're delivering on the measures that you've said as a part of our managed care contract. We're going to deliver on this to the state. The state also may be withholding payment associated with delivering on those quality results. And then I'd say the third is usually the question mark. Sometimes it's behavioral health. Sometimes it might be the state is rolling out a new initiative related to maternal health. So that's going to be our third plank. That's usually the question mark. Are you going to be the third if you're not doing 1 or 2 for the health plan? I think for plans that we partner with, we're often a third. Sometimes we might even move up to being a second priority for a variety of reasons. But even when we're not in the top 3, I would say we do 2 things pretty well. We can always get better at it. But one I would say is we show our work. And so what I mean by show our work is we live demo the product all the time. I've heard and now seen from plan leaders we talk to, but also from other founders or just other tech companies / vendors that sell. Most of the time it's slides, and then it's often a clickable link that somebody's going through. It does make a difference for them to see what the consumer experience is in a real way. That show the work, show me a real demo, show me a live demo. Even if you make a mistake as you're going through your live demo, that feels real. That shows who you are, that as a company, your values. So I love showing our work. I think we get a lot of points for that. The second, after showing our work, I would say is make it easy. We use the term gravitational pull. There's a tax internally if you're a leader on getting something done. You know that you need to get approval from compliance. You need marketing to sign off. You have to get a financial leader to say yes, maybe actuarial, probably talk to someone in finance, just all of that. That is essentially what you're asking somebody at a plan to do. So you need to make it so worth their while. I want that leader that we work with to win. I want them to, by moving us through, get an A+ and 3 promotions. I want them to be the plan president, in X number of years. So we need to make sure our financials work in a way that gets a thumbs up from the CFO, or our pilot approach and our pilot payment, or how much it costs, needs to be free to extremely nominal, because you don't want that to be a barrier. You need to have everything ready to go as let's say if you need marketing sign off, this is ready, and here's how we know it's going to get approved because we've talked to the state before. All of those things that you can sort of create a glide path, because you know exactly what needs to get ticked off internally, and keep everybody on an implementation timeline or schedule. It really helps.
Yeah, I love that. Make it easy, demo it, make it real, give them a glide path.
Yeah.
It's all logical things.
Should I go turn that off? Sorry.
That's fine.
Okay.
No, it's all good.
Okay.
Can you tell me a story of a time where you felt like someone didn't understand the product and then you demoed it and their eyes like opened up and they're like, oh, I get it. Like, has that happened?
Oh, all the time. I think the concept of what we are building, if you've been mired in the day-to-day of Medicaid for the last 10 years, you think and have seen it be a very paper-based process. Maybe you used to do field work or community engagement yourself, particularly with some of the hardest to serve people. Your framework of what you think is possible might, it's set in a different place. Then when we show our product, especially if the concept of TurboTax doesn't land, because sometimes people think TurboTax and we're making a consumer pay to use our product, so the analogy only goes so far. Then they see going back to what I said earlier, show your work. I think that's when people are really impressed and blown away and excited. Sometimes they say, okay, you've built this slick experience. It looks nice. But then there are perspectives people have on the Medicaid beneficiary or people on CHIP, et cetera. And so we're, trying to both convince them and walk them through their assumptions and how we fit into how we believe that, and we know 90% of Medicaid beneficiaries, even more, have a cell phone. So a lot of the preconceived notions from maybe 10, 15 years ago don't apply for right now. So sometimes we're walking through some stereotypes and assumptions, but I would say by showing the product, and then our pilot results always will speak for themselves, that's when we've usually convinced someone. So the eyes light up at the demo, and then people are excited about the ROI after the pilot.
Yeah, I love that. I think the biggest learning for me when I first started working with a lot of plans was that the person who you think you're selling to is one of probably 5 that actually are going to be signing off and making the decision together. And you're probably only going to meet 3. So like to your point of making it easy, making it demoable, it's like you are also arming the person who is your champion to be able to make the internal case for you for the people who are probably never going to meet you. Like, I've never met an actuary, but I know that there's an actuary involved in every single one of our conversations. Yeah. And I don't know that I'm ever going to meet an actuary because I don't think they take meetings with people like me.
You might. When it first happens, you're like, oh, hello.
That person is going to become my best friend because I think about them all the time. So I think it's really interesting. You talked about how the data piece for plans is a problem. It sounds, I've also seen it too, like there's still a lot of legacy operational procedures that these plans have, especially if it's like a regional plan who maybe hasn't had the benefit of having a national arm kind of giving them new stuff. Like what is the other, outside of even the problem that Fortuna is solving, like what are just some of the things that you feel like you've heard piss people off and that need to be solved, or problems that you feel like airing out might give someone at a plan who's struggling with it, like help them feel validated that they're not the only ones going through it?
Oh yeah, this is a good one. I would say there's a lot of stuff in call center, just generally. Call center is bearing the brunt of, and also holds the keys to, here is what consumers and members care about. But oftentimes they're under-resourced, people are paid less than executives. And so there's, I think, a lot of opportunity there for people who are leading call centers or call center reports up into their P&L. I think there's a lot of opportunity there, including AI and other things to improve it. Quality is another huge area. There are so many things that states require plans to do and do well. As an example, increasing or making sure you're hitting a certain vaccination rate on, children under 6. That requires someone to be both setting the strategy on how to do that, engage it, operationalize it. You're asking a lot of plans and both executives and people that are managers to go and make that happen. I think there's a lot of opportunity to support quality initiatives. And then the third, I would say, is the clinical areas that cost the most to plans and still don't have the perfect solution. I'd put primary care, BH, maternal in that area specifically for Medicaid plans. And then if we're talking about duals, then there's slightly different contours on, you're managing a lot of chronic conditions for a lot of people that have a lot of social needs as well. And there is just a deep amount of case management work that goes into people who have, on average, 5 chronic conditions. It's a lot of management, a lot of time, a lot of resources. So I would say that last band is just the really important clinical and social needs associated with some of the high needs members.
I think something that comes up a lot with the Medicaid population is engagement. And I think it's something that your solution aims to solve, our solution aims to solve. What have you learned? Because I know that the precursor to doing all those things is like you actually have a member who is engaged, first to be able to get benefits, second to be able to use the benefits. What have you learned about getting Medicaid members to engage and re-engage with their plans, either through Fortuna or even just in general?
Yeah. One, it starts with how bad the data is. And there's no blame game, but there's a lot of stuff that has been set up in a really challenging way where managed care the plans don't get accurate data, don't get full data, or the data that's sent over gets written over if you put in accurate data. Is
this just because the states have legacy systems that are managing it? Or?
Yeah, it's a lot of the legacy systems. It's the way that data is not validated before it's sent over. I'll give you an example of this. In a state that we operate in that will go unnamed, it doesn't validate what number you're putting in for the phone number. So you can get numbers like 1111111, right? That's obviously not a real phone number. Very easy way to prevent that from happening, but there is not infrastructure involved in ameliorating that. So small things like that can go a really long way because it impacts everybody's ability to serve the member. So I'd say data quality, that's a really important thing to generally solve for Medicaid. Then on the engagement part, what I have found is it becomes a responsibility of us and our plan partners to make sure that not only do we have, to the extent that we can, have fidelity on the data, but that we've identified the right people. And then after identifying the right people, that we're also communicating to them at the right time. So as an example of this, let's say we're focused on all the people that are up for renewing their Medicaid in May. Let's make sure we have the right set of data of people that are renewing in May, obviously number one. But then after that, when do you send them that message to renew? If you send it 10 days before renewal, that's challenging. If you send it 60 days before renewal, well, you might be maybe that's too far out. There's actually a partnership involved in figuring out when do you initiate communication and do ongoing communication with plans. We can get into some of the nuances. I know you know this around like getting state approval on some of those messaging, but I think that this is somewhere we don't have to reinvent the wheel on engagement. One, there's a lot of companies that are doing engagement work in order to give access to the member, the service that they're providing. But second, separate and related to that is looking at what consumer tech companies do really well. What can we learn from them? As an example, Duolingo, the way that they engage and send you a notification to come back, they send it within the 30 minutes of the last time that you used the product. That's brilliant because they know you're most likely to re-engage with that around the same time that you did last time. So why do we have to always send a message, let's say at 9 a.m.? That doesn't make sense maybe for almost everyone.
Yeah.
Can we take learnings from outside of Medicaid, from outside of healthcare, and just go, this is straightforward and makes sense. Why don't we apply these same principles to engagement?
Yeah. And I guess on the counterpoint, it's like, man, for the work you do, like that's a big thing that you do once a year. Like you can't build a habit around that, right? You can't build Duolingo every day. I'm going to spend 15 minutes after I'm on the toilet after I get home from work, right? Like it's different. And going to your doctor, going to your primary care, like it's not an enjoyable thing for a lot of people. I think especially for communities that have had historically disadvantaged challenges where they don't trust doctors or they have, rightly so, right? Like it's not necessarily culturally built in. And so I think to your point, there are problems that I think that is appropriate for, and I think there are also problems which like need very different solutions, right? Like, how do we go into a community and actually start getting people to value their healthcare, value behavioral health?
Yeah,
that's a much different challenge, and on the flip side, that is all behavioral health, like behavioral design, right? Like all of this is human behavior, engaging with healthcare, being proactive about your health insurance, making sure you're taking care of yourself. Like all of it is behavior. And so I think all the learnings can be used when you're thoughtful about it.
Totally. And I'd say some of it is like, it's very much designed. A lot of it's public health, but it's in these really subliminal ways that this has nothing to do with healthcare, but I thought it was related to what you were saying. I noticed a couple of weeks ago on the New York City subway, every time there's an announcement that's a warning, it's said by a male voice. Every time it's informational, the recording is done by a woman. And I'm sure that they hired McKinsey or somebody out there that did this research to try to do what is going to be the best way to get people to take the actions that we want them to take. But those types of ways that our world is designed, or the ways that people like think systems aren't set up, so how they do or don't trust the healthcare system, there are ways outside of the healthcare system that we can promote trust and better behavior. This is not my tee up for Maha, but there really is. Like, whether it's looking at just what do good consumer companies do, or just looking at outside of healthcare, like, I think there's a lot to learn from.
And I think what you said in there, which I very much resonate with, is everything is designed. Like, all of the legacy systems that a state is using to send information to health plans, like, somebody built that at some point in time. And if that was built 50 years ago, they did not have access to the information and the technology that we have today. And I think I got this very early on, which is like, take none of it for granted. Like, the chair that you're sitting in was designed, the table, the health plan incentive structure, like, all of it was created, which means all of it can be recreated. And I do find that, especially in the deeper you go in healthcare, I think the more people get disillusioned and the more people feel disempowered to actually change stuff. When in reality, like, it's just a complex web of systems that are not perfectly designed and will never be perfectly designed, but there's always going to be ways to jigger and shift stuff. And maybe that's my naive, optimistic take, but I imagine you have a similar belief as well.
Oh, yeah. I think you have to do the work that we do. You have to be really courageous that it's possible to change the system, and having people around you that also believe that. It's funny you mentioned 50 years ago, it was built this way, and then policy change upon operational change upon policy change. That's what we have today, this really weird Frankenstein system that is most often than not built off of good intentions. Jen Pahlka, the woman who wrote Recoding America, on how a lot of our infrastructure, particularly on the government tech side, has been built off of the cleave between where policy starts and where the operational rubber meets the road. There is so much more we could do to make those better, but also not be afraid of, let's remove stuff, let's change things. If it means asking the prompt that nobody wants to ask, what if you rebuilt Medicaid E&E as an example? What if you rebuilt behavioral health for the 21st century? Let's remove everything that came before that. What might that look like? Yeah. And if you start with that prompt and then you get excited about it, does that actually maybe incentivize people to go, okay, yeah, let's get rid of what we had before and let's build up something new. But it takes a lot of will and courage to have the conversation and then take action from it.
Yeah. And there's something really sad about human organization, which is, it seems like unless you explicitly code it in, removing stuff is never incentivized.
Yeah.
Like, there's never an incentive for a politician to say, we're going to remove a bunch. Even if they say we're going to cut something, we're going to add new things that cut your taxes or whatever. There's never a let's simplify. And good systems, and every physicist or scientist knows this, good systems, good solutions are simple because they distill something down to its essence. And it feels like in healthcare, you've had change and add upon change and add upon change and add, when in reality, like, a much simpler system would be probably much more effective. But because you're dealing with human lives, you can't just tear it down and start something new. You got to find a way to get from point A to point B. So I love the idea of simplicity as the core driver and removing rather than adding. I asked this question to sort of everyone to kind of wrap up the conversations.
Yeah.
You obviously spend all of your day thinking about Medicaid. I think probably more than literally anyone. There's lots of problems. I think you are tackling one today, which is a very important one, but there's many more. And all of the problems have impacts on patients and people. And we do have this system that is going to take a long while to change. But if you had the ability to magically snap your fingers and rewrite American healthcare to be what you think would be better for patients or members, or in whatever way you wanted, you had the power to just snap your fingers, what would you snap your fingers and do?
I would increase access to care by increasing physician supply. I think that decisions that the American Medical Association made 50 to 100 years ago of constraining the supply of doctors, consequential effects of that constraining the supply of nurses, that is what has caused so much of the problems in our system. There just not being much access to care, nobody going into family medicine anymore, nurses that want to go to, med spa instead of, stepping in and going at the top of their license to be, in some ways, a family medicine physician, and also the extremely high costs of care that happen when you naturally constrain the supply of the clinical labor force. If there's anything at all that I think could materially bend the cost curve in healthcare and therefore make it better, it would be, let's increase the number of people that are physicians, can be physicians, even nurses. But that would be my magic wand. Yeah.
Okay, so we need more universities. We need more people training. We need more investment.
Yes, all of the above. I genuinely believe we need more physicians. The number of physicians, this is my other soapbox. Now you found Medicaid and physician to supply.
Love it.
The number of, if you look at specialties where the average age of the doctor is the average physician in, bariatric surgery, I'm picking one, but, nephrology even, is in their 60s. That is not a good thing if that's how old the average doctor is. That tells you everybody's heading into retirement. We're going to have an even bigger supply problem than we have today. That should be a crisis. And it's a thing that a lot of people know about, but we all feel like we're stuck in a rock and a hard place for how we solve that. A lot of it comes down to the medical associations, CMS stepping in, and I think actually AI also plays a role in increasing access where there's not physicians, but yeah.
Yeah, totally hear you. It is a really hard problem because you're talking about policy incentives, and you're also talking about people making decisions on what to do with their life.
Yep.
I like Naval Ravikant on Twitter, and one of the things he said a long time ago that really stuck with me was like, in the future where everything is abundant and AI is doing all the work for us, everyone is either an artist or a therapist. And
I like that.
I sort of resonated with, which is like, we're going to need people to do things for us. We're always going to need care. We're always going to need support when we're going through a hard physical time, whether that means it's someone taking our blood pressure. That might be done by robotic systems or whatever, but we're still going to need someone in there to help console us and coach us through that. That doesn't go away ever. And so I agree with you. I am equally concerned about the supply of provider problem. I'm really hoping that we can solve it. We're tackling that from the peer angle. I think that partly solves it, but it doesn't necessarily solve the overall problem when we're talking about physicians and surgeons and medical doctors. But it's definitely an inspiring problem to solve.
Yeah.
What is one way people can find you, reach out to you, and what is one way that if anyone listens to this and they want to help, how can they support you?
Yeah, so you can definitely find us on LinkedIn and also at fortunahealth.com. You can email me, Nikita at, especially if you want to talk about all things Medicaid, the policy reforms that are happening. I'm always excited to chat with people about it and share what we're doing, especially related to work requirements, new 6-month eligibility recertifications for a lot of people. So hit me up that way.
Do you want to? I know we ran out of time here today. Do you want to give your one or two sentence overview of how the federal changes are impacting MCOs and what you think they can do about it?
Yeah, absolutely. So in 2026, 2027, and 2028, the federal reforms that are likely set to pass, we may see some changes, are going to increase some of the requirements for consumers and how they do their renewals. So either increasing documentation requirements, increasing the number of times you have to recertify, and then also if you are moving over to Marketplace, there's a bunch of reforms and changes related to that. There's a lot of policy. There's about 18 to 21 that when we were reading the nuances of the legislation that are going to affect plans. Plans need a strategy, particularly around work requirements. How are you going to be demonstrating or helping your members prove either every month or whenever the cadence is that they meet those requirements and therefore can keep their coverage? So that's something that we're passionate about. We're supporting it already in how we're building new product features. So if you're a plan, as an example, or a leader that's listening to this and you want to talk through how you're thinking features you'd like to see built or data you'd like to see, we would love to chat with you as we're building out some of those features.
Cool. Awesome.
Yeah.
Thanks.
Of course. Thanks for having me on.